Hello, everyone, and welcome. My name is Corey Thornton. I'm the Managing Editor for Market Intelligence at Open Minds. Today, as part of our weekly Executive Web Forum series, Open Minds Senior Associate Dr. John Talbot will moderate the discussion Emerging Models for Integrated Whole Person Care, featuring Dr. Dennis Freeman, Chief Executive Officer for Cherokee Health Systems, and Tine Hansen-Turton, President and Chief Executive Officer of Wood Services. Thank you to NextGen Healthcare, the generous sponsor of today's webinar. NextGen is a leading provider of ambulatory-focused technology solutions with a strategic focus on integrating medical, dental, and behavioral health data into one record on a single platform. NextGen solutions provide a comprehensive view of patient health, enabling a whole person approach to care. Before we get started, I have a couple of housekeeping reminders. While your audio will be muted for today's briefing, if you have any questions at any time, please enter those into the GoToWebinar question box and we'll be glad to answer them. If we run out of time and we haven't reached your question, please reach out to me to cthornton, Thornton, at openminds.com. Finally, the slides and recording for today's briefing will be available on the Open Minds website starting tomorrow. With that, I'd like to turn it over to John.
Thank you, Corey. And hello, everyone. I'm John Talbot. I'm Senior Associate with Open Minds, and really looking forward to our discussion today. Our speakers have just variety and wealth of experience in this area and some very different perspectives, which will make it, I think, exciting to really look at what's going on. So let's begin with just a couple introductory items. And Corey, if you could please advance the slide. Our agenda, we're going to start off with just high-level look at definitions of integration, some current and evolving integration models. Then we're going to proceed to the Cherokee Health Systems case study, then the Wood Services case study, and then a roundtable discussion. So again, please, any questions that you have, please submit them and we'll try and make sure we cover that. So, Corey, next slide, please. So let's start off by kind of looking at the definition of integration. And the reality is that there is not a single definition of integrating care between specialty healthcare providers, be it behavioral health. In this case, we also are looking at providers targeting the population with intellectual and developmental disabilities, and then sort of the broader healthcare system. And what kind of drives this lack of a single definition? Well, there's a lot of things. One is the models will vary in different markets, and that can depend on how information is shared. You know, are there exchanges, state exchanges that are being used? Are providers doing other things? Are providers really integrated that within their own organizations? How services are delivered? That again can vary by population served and the payment models, which goes to the third bullet there, which is the financial incentives among the stakeholders. They can vary widely, and we'll see examples of that and talk more about it. And those incentives ranging from traditional fee-for-service models to once you get into value-based kind of models, then it really shifts it around. So we have that. The models then will also impact things like service lines, you know, what kind of services are being provided, revenue, how that comes in, margins, and sustainability, which is a key one, which has been a struggle for some providers who have tried to do integrated models. And we have people here that have, you know, looked at those challenges and done really good work in that. So we're looking forward to that, because sustainability is critical. So maybe the fundamental takeaway here for people that are looking at getting into this, and even those that are in it perhaps, one, it's really critical that the executives leading all this, they have to understand your market, realizing the markets are going to be different depending on the population served. But beyond that, it can vary from state to state. Sometimes it can vary from county to county. So you have to understand your market and then determine what model is the most relevant for that market. So we're going to go through two really exciting and fun case studies, and then really want to tap in, so keep your questions coming, to the brain power that we have here that's going to be doing the presentation. So no pressure, guys, by the way. Anyway, so without further ado, let's move, Corey, please, to the next slide. Here are 10 models. These are broad, high-level models that Open Minds is seeing going on right now that are happening and all impacting service delivery. One, virtual specialty care that is embedded in health plans. So that's one model. Another one is, so what's some of the things, distinguishing things there? Notice virtual. So in this case, you're having health plans that are providing services, but now it's embedded within that health plan and it's virtual. Another ones are whole virtual specialty health plans. In other words, health plans that are targeting specialty kind of populations and they're providing services virtually. Primary care services with tech-enabled specialty care. Virtual hospitals and telehospital medicine. Children's consolidated care. And again, these are all integrated models fundamentally, but you can see either they're specialized or their treatment, how they're delivering services are very different. Health plan and health system provision of long-term care services. Expansion of the retail health concept, which is things like CVS, Walmart, all these people that are getting into providing now, not just primary care, but they're starting to expand to really a broader healthcare concept. Health plan sponsored, high-tech enabled in-home primary care. So in the difference here, it's not necessarily providers leading the way. Health plans are sponsoring it and they're doing it. Health plan working with ACOs or health systems to really align risk together. And then fully integrated health plan, health system models. So, you know, it's nice to know that we have things that are constantly evolving and new ones happening every day. But it really illustrates how complex our systems are right now. So, next slide. So, I would like to turn over the discussion, and we're very pleased to have Dennis Freeman from Cherokee Health Systems. Dennis, take it away, please.
Thank you, John. So first, I want to commend Open Minds for keeping whole person care and integrated care, you know, on the table in front of your nationwide subscribers and your audience. And I'm pleased to join that chorus and share some about Cherokee's integrated model of care. Next slide, please. So, you know, the focus on whole person care, focus on integrated care is really of fairly recent origins, but you know, the reasons for it are longstanding and have been known really for decades. Access to behavioral health care is inadequate. Well, as far as I can tell, from the first behavioral health professionals that walked the face of the earth, access to behavioral health care has been inadequate. The National Association of Mental Health publishes data annually, I believe, and they look at access. The most recent publication I saw from them, 19% of the population in a year's time have a psychiatric diagnosis and need care. 1 in 3 actually do not find care. Those numbers have not changed in the past decade. So access to behavioral health is inadequate, has been inadequate. It was 1969, and I was a young psychologist working at a community mental health center. And my boss said, you know, we just got this new federal grant and we need to be providing care in these rural counties around here. So please go out there and find a place to see patients. We can't afford an office, so just find a place to see patients. And I stumbled into primary care. What I saw changed the course of my career. The people I was seeing in primary care were indistinguishable from the folks I was seeing back at the mental health center. Same level of psychopathology, same issues. There were just a whole lot more of them. When I tried to refer them to me back at the mental health center, They looked at me and they laughed and they said, "No way, I'm not going there. That's for crazy people. I'm glad to see you here, but no way will I go and see you there." So I concluded back then, really, the place to see patients is in primary care. There are just a lot more of them. The primary care is generally the gateway to healthcare in this system. 80% of the population have a primary care visit over a period of a year. So I think for behaviorists who want to see most of the people who need that care, primary care is really the place to be. Our healthcare system works sometimes for some, but certainly doesn't work always for everyone. We have the most expensive healthcare system in the world. 16.9% of our gross domestic product goes to paying for healthcare goods and services, and yet we don't really have really good outcomes compared with other systems. The Commonwealth Fund did a study looking at the 11 nations, most industrialized, most modern nations on Earth, and they ranked on a number of different things, life expectancy, different kinds of clinical measures, cost. US came out 11th out of 11 on virtually every measure except cost, and we were number one. So system doesn't seem to work too well. And part of the reason I think is that we have such a siloed healthcare system, and referrals between those sectors often don't connect. We hired a physician a few years back who had his own private practice. He had located in the most exclusive area of Knoxville. So all of his patients had commercial insurance. They all had good behavioral health benefit. He said, referring to behavioral health was like putting a note in the bottle and throwing it in the ocean. So the siloed approach doesn't work too well for a lot of folks. A few weeks ago, I saw a specialist at our local teaching hospital, and I asked him what I thought was a pretty basic medical question. And he seemed annoyed by the question, and he looked at me and he said, "Buddy, it's been a long time since medical school. You could ask him about anything in his specialty." He's top drawer, he knew it all, but not so much for the general medical knowledge. I saw a patient yesterday, actually, who had seen a primary care provider, not someone in our system, but the primary care provider said, "Since I saw you last, you've gained 20 pounds. Your blood pressure's up, your cholesterol is up. You got to do some things differently. You've got to eat better, and you've got to exercise. And I'm going to see you back here in 3 months, and we'll see how you've done." I doubt that provider had a clue that this patient lives in public housing, has absolutely no income. He eats at food pantries when he can. He gets handouts from people. I mean, sure, his diet is terrible. In addition to that, he's actively paranoid, actively delusional. I can't get him to leave his apartment because when he's out there, he sees other people and he's sure they're talking about him and plotting against him, and he's hearing voices, and none of those recommendations are going to work, right? Next slide, please. So Cherokee began as a community clinic providing mental health counseling. It became a community mental health center when that was possible. And I came there in 1978, and I'd had this early experience that you heard about. So we started reaching out and delivering consultation in primary care clinics. In '84, we opened our own clinic in an underserved area, gradually kept expanding our clinic, and then eventually became a federally qualified health center. So today we're both. We're a licensed community mental health center in the state of Tennessee, but we're also a federally qualified health center. and probably to most people on the outside look more like an FQHC than a CMHC. In our clinical model, and John's right, you know, the integrated care as a term has really kind of lost meaning. People talk about a continuum of integrated care. So we use the word blending. We blend behavioral health professionals, specially skilled, specially trained behaviorists who are part of the primary care team. They're right there located within the primary care arena. So patients come in, they see a primary care provider, they might go to the lab, they might get x-ray, or they might see the behavioral health professional who works with the primary care provider during the visit, actually during the visit, to decide what's best care for this person going forward. So it's a blended, integrated behavioral health model in primary care. We try to provide as much comprehensive care as we can. You'll notice you have a list of our staffing profile later, I think on a slide, and people look at it and they're surprised that we have 29 community health workers. You know, these are folks that are field-based for the most part, in homes, you know, helping folks with the psychosocial aspects of care, the health, social determinants of health that we read and hear so much about now. And that's really got to be part of care. Like most safety net providers, we're a mission-driven organization. Values about care are really important. We hire to those values. I think my primary job as a CEO is to be a custodian of those corporate values. We see anyone who wants to come, open door policy, but we have a special heart for those who really have no place else to access care, the least, the last, the lost in our communities. 30% of our patients are uninsured. We are, I think, one of 13 states that did not expand Medicaid. It's a challenge, especially to find care outside of our system for those folks. So financing is always interesting, if you will, and I think we've been relatively successful keeping the place open and going. We have some strategies that I think help us with that. We really try to be partners with payers. We try to teach them as much about our model as possible, sharing a lot of data with them, and try to work on contracts that match our model. We always look for global payment when we can. You know, if we can be prepaid, if we can have per member per month, if we can have case rate, whatever, to be paid in some model that allows us to cover all the activities that are really necessary in healthcare when there's not a CPT code for those. So we try to avoid fee for service whenever we can. Next slide. There are always new things in healthcare, and these are some that we've embraced. I won't spend a lot of time on these items. We might want to talk about them later. But all of our contracts now with payers have value-based components. So we're collecting data, clinical measures on these people, HEDIS measures, reporting those back and forth. And there's usually a quality gate and a financial gate, and so you have to cross each of those before you end up getting some payments. So we've built out a pretty strong data analytics department, a care management, care coordination department. And I think in our budget this year, we expect to augment our clinical services revenue by about 8% with value-based payments. I personally think we might do better than that, but it's become part of the way we finance ourselves. Patient engagement, it makes sense you're not going to do too well helping patients if they're not engaged in their own care. For us, with these managed care plans, patients are attributed to us. So they're assigned to us whether we've seen them or not. And their data counts for us. You know, their healthcare costs count. They're part of our panel. So we make a very strong effort to try to reach out and get those people in care. And just because you're in care doesn't mean you're involved in your own care. So we really try to help people establish, clear goals and understand things. I see a young fellow who's floridly psychotic. He's delusional, but he knows what hemoglobin A1C is now. He's diabetic, and he knows that 7 is the number we're shooting for, and he's not there yet. And so he comes in and he says, "What's my hemoglobin A1C?" And then he talks about how he's on the side. He's going to be a linebacker for the New York Giants next year. So patient engagement. The pandemic has changed a lot of things in the delivery of care. One thing that it's done is it's really shown a spotlight on the disparities, the problems we have with health equity. We've known the data before, but now with the pandemic, the minority populations, the isolated populations are really bearing the brunt of COVID. So it's really focused a lot of attention there. We're pleased to see that, frankly, and have targeted special populations of homeless, residents of public housing, and agricultural migrant farm workers in our area. So we focus on those. We have a health equity committee as part of our quality council. So we look at data all the time about how those folks are doing on HEDIS measures and access and whatever. The other thing the pandemic has done is really shown us the broad-based benefits of virtual care approaches. We had done telehealth since 1999, so it wasn't new to us. But during the pandemic, we had a number of our therapists working from home and making phone calls to patients or having video if they had the capability of doing that. It's been just really wonderful to see how well that has worked, how much patients prefer it for the most part. And so part of what we have to do is to show the benefits of that so that some of the changes in payment methodologies, will continue beyond the end of the pandemic. And I think the last slide just shows, and you may keep that up, I don't know, but this just shows basically our provider staff. We saw pretty close to 70,000 patients last year. They look over a 2-year span, closer to 100,000. See the number of services, a lot of new patients. We really try to provide opportunity for everybody who wants to cross the threshold to get in. And you see our provider staff listed there. The thing that might stand out is the 2 cardiologists, 1 nephrologist, 2 dermatologists, 2 OB/GYN, and an infectious disease specialist. It's so hard to find specialists for uninsured folks, and so we're making an effort to bring some of the specialists in-house to work with our primary care teams. So great to have the opportunity to share some things about Cherokee, and look forward to the conversation to follow.
Thank you, Dennis. Appreciate it. And now, Tine is going to present the Woods story. Take it away.
Great. Thank you, John. And actually, it's great to follow Dennis because in my previous life, 5 years ago, I actually ran a large network in Philadelphia of federally qualified health centers. They were nurse-led, nurse practitioner-led, and I've sort of been in the federal qualified health center business most of my life until I came to Woods. And I'm jealous, and I'll talk about that because at least with, and I love what Cherokee has done. They've blended the 2 key parts of it. Integrating, primary and behavioral health care is key. It only works, like that. And I would say one of the biggest challenges coming to the intellectual disability sector is that there is no system. Talk about silos or even more. It is not thought about as healthcare. it's really thought about more as room and board and but divided into, and then social work. And I'll talk a little bit about that because at Woods, we try to put it all together. So a little bit about us. We are a large nonprofit, complex human services organization. We serve primarily kids, children and adults with intellectual disabilities, as well as adults with acquired brain injuries, and more recently also more people with mental health issues. But the common theme of all the populations is they all have complex medical needs, genetic disorders, and certainly behavioral health challenges. So it's really a challenged population. What we do is we call ourselves a population health management network or organization. We think we are one. It's not defined anywhere in federal law, anything like that. But when you look at what we do within our network, it is really what sort of Dennis talked a little bit about, combining healthcare, behavioral healthcare with all the social determinants of health. What's unique about a person with an intellectual disability is that if you're born with an intellectual disability, you will not necessarily get better. You'll have issues, you'll have life needs across the lifespan. That's that whole person, care needs you might have, but you'll have a need for services throughout your lifespan. So a group of us providers or more these days that are larger and that do all the things we do at Wood Services are beginning to say we need to define ourselves and are calling ourselves life cycle care management organizations, because our ability, Wood's ability, is that we can actually serve somebody that comes in our door until the end of life if they want to be and have the choice to be part of our network. So what do we do and who are we? So we are a network of organizations that have come together. We have locations in Pennsylvania and New Jersey, and we serve about 22,000 people. We're more known probably in most networks at Woods and Langhorne, where we have a campus-based setting, but that probably represents maybe 2% of the population we serve today. We are much more community-based with our, with our partners that are in the community. We have about 6,000, employees in our Woods network. And I just got to give a plug out that 2/3 of them are amazing direct care staff, not that different from community outreach workers, which I used to work with, Dennis, and I love, I love that, profession. The challenge is, I think, with all of the entry-level positions into healthcare is that we have such a shortage, and I just want to say that. And this particular, environment has not helped us because of the people now are able to stay home. So we really need support from the federal government to bring the workforce back. Otherwise, you're not going to have people that can provide care and safety for vulnerable populations like folks that are elderly and also the intellectually disabled. So our system of care is comprised of essentially 6 organizations that are affiliates or subsidiary corporations of Wood Services. And our model is very simple. We're the sole member corporation of each of the affiliates that have their own 501c3s, their own CEOs. And what I am very happy to say is I work with a network of incredible leaders, and together this is very much a group effort to put forward this idea of life cycle and a continual care services within this model of care, which we call the Wood system of care. Just briefly, Abilities is our workforce and arm in New Jersey. Allies is our group home provider in New Jersey for both kids, youth, and adults. Archway Programs has 2 day schools, and we provide a lot of services to the families in the homes. Legacy is a latest partner. They came on board a little over 2 years ago, and they are our behavioral health and mental health arm of Wood Services now, and their footprint, because they started as a community-based model, has really not only expanded in New Jersey, but also in Pennsylvania, and they've very much influenced the way we do mental health and behavioral health care now here at Woods and over the last 3 to 4 years. Tabor is a child welfare agency that's in Philadelphia, which is key because we do work very closely with Philadelphia and also serve some of the more complex individuals. And then Woods Community at Bryan's House is our group home provider and community-based provider here in Pennsylvania. And then let's go to the next slide, Corey, because I'll show you how the system works. So when you build this life cycle care management network, you've got to be intentional about it. We had a lot of bells and whistles when I came in. What attracted me about Wood Services starting 5 years ago, almost 5 years ago, was there was a lot of components, but we weren't working as a system of care. And that really requires the leadership to work closely together with all the levels of your staff to make sure you can do it. We've done it, and I'm really pleased to say that there is really that continual care when you walk into a Woods partner. So let's say, I just want to give you the example. If somebody at age 12 from New Jersey comes to Wood Services in Langhorne, Bucks County, they would usually only come here because every other system in New Jersey has rejected them. They'll come to us, they'll go to a school. here on site, on campus in Bucks County, and they'll get all the support wraparound services. We have a health center, we have behavioral health service, specialty care. We have all of those services a person would need. And later on, that person might need to get vocational training and ready to go back in the community and be more independent. At age 21, in our sector, the people with intellectual disabilities lose their educational entitlement and they go into the adult system, which can be a cliff for many. We don't want it to be a cliff for many because we have had situations where people left us over the years and they didn't last long. They died in sort of community-based settings that did not understand all of their, I would say, behavioral health care needs and primary care and also other kind of needs they had. So, what we now do is that we start a lot earlier. We work with the families and the young adult, and then we build essentially, group home placement within, or in this case, it would be allies with the right supports. They can continue a lot of the services they would have gotten here. They might be able to continue with the therapist and so forth. So there's not that gap, and you go into an environment that knows who you are, what your needs are as a person, and can continue with that supportive milieu that you need, somebody with an intellectual disability. Next slide, please. There might be a delay. Or is a delay on the slide? Yeah, there we go. So I just want to talk a little bit about how we are, the support service and how we do partnerships at Woods. So I've talked before at Open Minds about how we bolstered a medical center at Woods. As I said, I was very excited when I joined Woods. I thought there was so many components from my past I could bring into life. And we had a health center, always had a medical center here. However, it was not a health center that was operating more like what I would say what Dennis does in terms of the community health center model. And that's my lens. So we've done a lot of changes to our healthcare medical center at Woods, and it really operates as a federal qualified health center. I wish we could get a designation. Dennis, maybe you can help us on that, for intellectual disabled, because they really are complex and in so many ways cost the system more. And yet that's where you can get some of the cost savings. But when you have a medical center instead, we have primary care providers, both physicians and also nurse practitioners that serve a population, and our group home populations are also eligible for anybody within the Woods system of care can come to our medical center here at Woods. But of course, there's a lot of specialty needs that we need. So we have contracts with many different specialty providers. We don't send people out, they come to us. The specialty providers come to our and RL Health, which is in the captive, the medical center at Woods, will then bill for those services on behalf of those folks. But we've been able to do some interesting partnership, for example, with joint staff and joint staff privileges. So St. Mary's Medical Center, which is very close to us, our closest medical center, we actually have our physician has privileges at St. Mary's and actually also work at St. Mary's. So we're able to essentially get that coordinated care you want for this very complex population, seamless referrals, better communications, and all in all, having this medical center here at Woods has really also shown, and we work with Keystone and other Medicaid managed care organizations. We've shown that we can reduce emergency room visits and hospitalizations because we have those preventive measures. But all of this, I would say, is you're only as good as your partners. And I would say the key thing is for us is to have these relationships. Contracts leads those relationships, but by no means are there necessarily the cost benefits you'll see, for example, in a community health center. And next slide, please. So we have some models, and this is, I said that to John when we started. I think it was, I've again spoken a couple of times at Open Minds, and I think you're going to see the evolution of Woods over the next several years. Once Legacy joined us, we were able to provide a lot more mental and behavioral health supports, and we started looking at what are some of the key things that we want to do. We are, Legacy is a fantastic organization that has provided mental and behavioral health supports for years for kids and adolescents, and now also adults in New Jersey, and we are now replicating that in Pennsylvania. And what we looked at is that how can we better serve our community? And we have clients throughout New Jersey. We're much bigger in size in New Jersey than we are in Pennsylvania. Many people don't know that. But what we looked at saying, how can we partner and actually take advantage of some of those rates and some of those partnerships and benefits that various hospital systems offer. So here's one model we have done, which is a clinical integrated network, kind of what John, you said, that there are many different ways of doing this. The structure with a clinical integrated network is that you have contracts. It's a strategic partnership. You usually are doing something that hospital is not good at, or they're not investing in. So you have a benefit to them. And in this case, what we do is we really service at crisis intervention. When somebody comes to Shore Memorial, which is in Somers Point, and they have a behavioral health crisis, we're able to treat it there, or Legacy is able to treat it right there in our co-located at Shore Memorial, and take care of that immediate need for a response to a crisis. So it doesn't end up necessarily in a hospitalization, and we can serve the person right there. We also have a board seat there, and I would say that it really has become a great way to showcase how community providers can also work with medical centers. Next slide, please. Another model we have is a joint ventures, and this is something we're exploring in both in Jersey and Pennsylvania, maybe also other places in the future. That structure, a joint venture, I'm sure many of you know what that means. You combine ownership, an operating agreement. Usually, you usually have a management board director's oversight, and you can sort of have a full or partial integrated model and co-located services. In this case, we are working very closely with Salem Medical Center in Salem County in New Jersey, and we're doing that because Allies, which is a community group home provider, has a lot of clients in the area, and it's kind of a nice microcosm where you can really provide for an integrated model of care. Woods presents sort of the primary care side of it. We have the expertise in primary preventive care for development disabled. Legacy has the behavioral health arm and the crisis arm, taking care of people that are in crisis and needs. And then Salem Medical Center obviously offer a lot of services as part of the medical center. And we are co-located, in their medical. And actually, we both have services inside the medical center and also have a wing outside of the hospital. The outcome we've seen so far is certainly good continuity care, seamless care transitions, again, between inpatient and outpatient care. This can work really well, expedited referrals, like real-time coordination, because we can use the EMR. But important also is that we've really looked at this to say, is this a model to create sort of a healthy community? And we were very lucky to get from the New Jersey Department of Human Services, Division of Disability Services, a grant through CDC to really look at how do you provide what I call intellectual disability friendly care services for that population in a community. And again, we sort of built that out of this joint venture. And next slide, please. The last kind of model we have, and this is an easier model, is co-located services. In this case, we work with the virtual health, where we also are embedded in virtual system of care. Co-located services are great. You usually can do this with lease-based. The key thing is to have policies in place so you get referrals, and so you can actually have a partnership. If you're just co-located and nobody in the system knows about you, that's not going to work. You really need to have a partnership with where you are co-located, so they understand what you bring, and so the providers, physicians, nurses, etc., understand the services you provide and why they need to help shepherd clients your way. But the good thing is that operational autonomy, if that's what you want, is certainly easier than any of the other partnerships we've had. In terms of outcomes, it's certainly cost effective. It's usually cheaper to do it this way. And the levels of integration can be, again, robust based on sort of I would say the parameters of the policies you set up front. I would say that sort of just in conclusion, this is my last slide, is that I think there's lots of opportunities. I think one of the key things for our sector, the intellectually disabled sector, is that it's not come together as truly a sector. It's a various silos from various departments that fund the services. So we've had to get very creative at the Woods System of Care with all affiliates to really figure out how do we maximize the various service levels that we have to put it all, and how do we put it together. And we know if not us, then who? So we understand that. But I will say that, long term, and we really saw this with COVID, having all these healthcare services in place, especially the health center at Woods, was a game changer, a life saver for our residents. We had no deaths, but we certainly had a lot of people that got COVID. But we really got ourselves tested at how good are we at doing this, and we found ourselves that in many ways we were a microcosm of what was going on at the hospital. The hospital's right next door, but was just recognized as a place that provides room and board for the very complex people we serve. And that's got to change, and that's something, as I said, some of us are working on, because this is a very sophisticated sector, and about, I would say, $880 billion of Medicaid services goes into the sector, very tiny population that consumes all of those dollars. So it's ripe for being thought about differently, and that's where I kind of secretly hope, Dennis, and as I said before, that we can figure out how to tap into all that the federal qualified health center system have to offer, because that is, I've always been, really proud of working with QHCs, but I also think it's a model. It is the model, and we don't talk enough about it because it sets out to be integrated from the get-go. I'm going to end here and turn it back to you, John.
Thank you. Wow, good stuff. So both of you have really kind of turned the traditional, for lack of a better term, model of delivering services, like the traditional behavioral health, and then traditional services to persons with intellectual and developmental disabilities. And it sounds like it sounds to me, hearing that both of you were driven by kind of what you saw as really what it takes to provide better care. What do you think there's a lot of opportunities to do that, but what do you see, I guess, as the big challenges as we move forward? For each of you, what was the biggest challenge you faced as you started to create these new models and get them going? Or if there's a couple, that's fine too. But whoever would like to go first, what were the challenges?
Go ahead, Tine.
So there was a couple of things. One, stepping into Wood Services is a phenomenal organization. The leadership is phenomenal. But even starting out was first to convince and sort of open staff's eyes to the fact that they had all the pieces to create this population health network. So I think I started there first. It didn't take long. It was like the biggest aha moment, say, wow, we are all that. And then, so first you start with, I think, the culture of the organization. Very quickly, I think I had the benefit coming from Dennis's world that I have worked with managed care. I have contacts everywhere. So the first thing we started with a medical center, I said we'd never built for services. We were essentially, and we also, I never mentioned we have a dental center as well. But we sort of said, let's begin to operate more as what I say, community health center, even though would never qualify given our location to be a community health center. And that began to be, that became the difference. And I will say it was not hard to do that shift here because the medical staff already understood this. They'd been there. So I think they liked the fact that they had somebody coming in here understanding the value, that health, preventive, et cetera. It was kind of taken for granted in a good way. But that is, and then I was looking at an organization where if we don't turn this into much more of healthcare, this sector is not going to survive long term the way it is, and people are suffering because they get sent out in communities where there's no support systems for them, and there's no disability friendly care. I mean, because most providers are not inept to handle somebody who might have a psychotic episode as they come in for care. A community health center would, Dennis would, but most of primary care in the community, you have somebody with autism that are screaming and hollering and might start getting aggressive. That is my world, and again, it requires a very different look at how to provide care. So I would say it was getting the team on board first. Then the healthcare team was sort of the champions when they realized where I was trying to take people, and then I think the rest is sort of history. Is that we are, but the third challenge for us is that we're putting the pieces together, but I'm relying on these hospitals to get the hospital rates. We should be able to also be directly reimbursed. We don't necessarily always need to be embedded in a hospital. We know that we can do those services ourselves, but there's limitations to that now. And I don't have a wraparound dollar rate like Dennis has, which is part of the federal qualified health system. Yet it takes at least an hour, if not more, to see a person in a primary care visit. So same thing with behavioral health. So there's a disconnect from the federal level onwards down to the state levels and the community levels with the development disability population. It's not nobody's fault because it was developed primarily by teachers and social workers. And that was Woods was started by a wonderful school teacher. So it was many other agencies that wanted to provide education services. And then it grew into a true population health network. So that's the challenge. So, and I would say the biggest thing now comes to convince the federal government, starting there, and also the states, that we are something else now and to take advantage of it. And I go back to we are $880 million, actually $1 billion, I'm sorry, of the Medicaid budget, and And yet nobody has figured out that actually maybe if you start providing some of these wraparound services, some of these strategies that Dennis and the community health center movement have done for years, you can actually save money.
I'll start kind of where you ended. You know, anytime you try to do something different, there are all kinds of barriers, you know, because a community mental health center is X. And so when we told our Department of Mental Health many years ago that we were going to start delivering primary care, they said, you can't do that. And I said, no, we're a not-for-profit corporation. I mean, we see the need in the community. You know, I didn't say you can't stop me, but essentially that's what I meant. So we put it in a separate corporation just to sort of help them swallow it. You know, they were afraid that their dollars were going to go to support primary care. Now they're proud of us, but you know, in the early days, I remember a deputy commissioner referred to our primary care clinic as Cherokee's harebrained scheme. Okay.
Really?
And then the payers, you know, they're not used to paying for things differently. And you're right, Tine. I mean, if they look at the data, you know, they look at high cost members, what you're doing is terrific. And I'm sure you're saving the payers money. They just need to figure out, you know, how to support what you're already doing. You know, when we put behaviorists in primary care and we said, you know, this is really not psychotherapy. This is a brief behavioral intervention, but it should be paid for like brief psychotherapy. Well, that didn't go too well for a while, but then new CPT codes came to really define that kind of care. But even getting the payers to put those codes in our contract took quite a few years. Now, you know, they're there, and you know, the health behavior assessment codes are well recognized, but it's basically a 10-year battle to get simple codes, you know, that was saving money. Clearly, briefer interventions, you know, at the primary care level save health plans a lot of money. But it's just hard sometimes to get the bureaucracies to consider new ideas.
It sounds like both of you, a critical element was being able to demonstrate, to put in this term, the value of this integrated approach. And have you had to make more investments, and you see more coming? I guess that's kind of a loaded question or a leading question, but in technologies to be able to track value measures, cost measures, all that kind of stuff. Has that been something that you have both had to do serious kind of investments in technologies to allow you to do that?
Yes, absolutely. Now we had a program evaluator, you know, in the 1970s, you know, to try to get data to prove our case. But now, like you say, John, the data is available generally, you know, from, you know, health exchanges, information exchanges, from payors. We have a lot of data ourselves. You know, we have a data warehouse, and anything we can find out about our patients goes in there. So we've got people running reports constantly. We've got a dashboard. So when a clinician opens the case for their visit, a whole lot of basic information has been gathered and shows up there. You know, gaps in care, you know, the latest health indicators from lab. It's the person in the hospital recently, you know, they've been in the emergency room. All those things are just immediately visible to the clinician, so they don't have to go back through the electronic health record and find those. So, yeah, I think for us to have that capability, to have programmers and people that really think in terms of data has been absolutely critical. With value-based contracting, payers don't always have accurate data. They might have a lot of data. It's interesting to find that sometimes their data is not exactly accurate. And so just to compare, you know, what we know about what we've done with folks with the data that they've got available has been eye-opening sometimes for everyone around the table. But it's expensive, you know, it's expensive to have the capability, but absolutely vital, pays for itself.
Yeah, and John, we've had, because we're a network of care, so, you know, one of the things, the first thing we spend millions of dollars in sort of infrastructure developments. Actually, I walked into a paper, an organization that still uses paper, so got to push for the first electronic, health record here. But today, we actually, all but one, except it still speaks to each other, use the same electronic health record across all the systems, which is key. We are partnering with that now. We actually have a separate, a standalone electronic medical record in the medical center. Not great because it's not integrated with the health. Remember, we're 24/7 care. We take care of people 24/7. We want to integrate it, right? So, because that's where you're going to do everything. So we are now, we're actually going to be the pilot or the beta site for this particular EHR we're using to, they recently merged. So use actually the other party's electronic medical record. If it all works, you'll know in December, and then we'll actually have an integrated EMR and EHR. That's going to be a game changer for us. Now you're going to see the picture, all the social determinants. We have incredible staff. As Dennis said, we have now 2 programmers on staff. They were not here when I started. We have another a guy that's brilliant with data at Legacy. So we are looking at dashboards. We have a doctor that does quality for us. So I would say the next iterations will really be looking at, when you put it all together, what are the outcomes, what are the cost savings. So I would say, John, ask me a year from now how it all works together, and really we obviously have contracts for some value-based care. However, I think we will be an organization much more on data steroids a year from now. Especially if we can get that the medical record integrated with EHR, that is a game changer for the industry. And that's another thing that in this industry with intellectual disabled don't have. I came from, again, an FQHC where at least there you had, I started, I think, implementing my first electronic medical record when I was like 25 years ago, a long time ago. So this is not a sector where there's a lot of sophistication. You certainly have, the sponsor of this is great. There's a lot of great, new softwares, but it's emerging compared to, the healthcare system that have had EMRs for years. So again, we are a little bit behind to do some of those things that you can do in the healthcare setting, but no doubt, millions of dollars to support this infrastructure to get to where we are. And we've been lucky. We've been able to fund it in various ways. I have a great board. That's supportive of this, but it's cost us a lot. But we need it. You can't do it. All of what we're doing as 2 organizations, you can't do that without these systems.
How has, both of you mentioned impacts that COVID certainly has had. Tine, you pointed out how it really exacerbated the fact that kind of what you're doing doesn't fit, and it's like the model that you're doing, which really sounds like it's meeting the needs, but COVID kind of exacerbated that. Dennis, you talked about the same kind of things. But a question, have you found that, both of you talked about virtual care. Do you see the future of integrated care involving much more of a continuing hybrid blend of virtual technologies and face-to-face? Do you see that as being part of the future? And what other things has the pandemic done to impact both of your integrated models?
Well, we always knew the capability was there. We started doing telepsychiatry, 20 plus years ago, and we didn't have enough behavioral health consultants to cover all of our primary care. So we teleconferenced behaviorists into primary care teams. So we've been doing this for a long time. What really changed with the pandemic was we had to cut down on the density of people in our clinics, just to cut down on the risk of infection spread. So we sent people home that were not necessary for the clinic, and we sent a bunch of our behavioral therapists to work from home, and had to change the workflow in our clinics. People came in and they were COVID possible. We took them down kind of one corridor, and it was kind of the routine visits. We took those down a different door. So we really, I think, learned some things about the efficient use of our space. We modified some space, but clinical flow. I think the threat pulled our staff together more. We started 2 mornings a week. We had 7:45 calls, just for all staff that wanted to participate for 15 minutes. And our medical director really kept up with what was happening with, COVID and vaccinations, and she kind of updated everybody. Our operations person talked about modifications we were making. So it kind of kept staff on board that way. But the biggest impact I hope that will continue are the virtual visits with patients. I see about 10, 12 patients a week, sometimes a few more. All my visits for the past year have been by phone. And I have been amazed at how well it's gone. I have one person who has a long history of psychosis who refused to get telephone calls. Initially, she wanted to see me in person. She now sees me by phone once in a while. But other patients love it. The convenience of it. They don't have to get dressed up. A lot of people have transportation issues, and just to get dressed up and go to the office is a real challenge. And I think we've all found that patients are more focused, so you can do a lot in a 30-minute visit with a patient. And even patients that I've seen that are actively psychotic, they seem much more focused when I talk to them on the phone than when I see them face to face. I think there are just too many distractions, for them, and it's a simpler environment. And my sessions, I think, are more meaningful. So I think it saves money. It saves wear and tear on patients. So we're doing all we can to lobby to make sure that telephone visits will continue.
Okay.
I think there's more support probably for virtual visits, and we do some of that too. But we have areas where broadband it's not found them yet, and we have patients who don't have the technology to really do, virtual visits. So those things, as well as home monitoring of things. There are all these devices now that we're investing in some things that patients can go home and take their blood pressure readings every day, and it's transmitted directly to the electronic health record. So innovations like that, are really going to improve
And
care.
John, I would say, John, I think, what you're saying, Dennis, is that a lot of, technology enhancers definitely, I think the COVID, pandemic showed us that we use telemedicine, telepsychiatry, and we have to, because there's a lot of group homes that we serve our clients. We're going to put that on steroids. That's going to be new investments in the future. It worked our population is challenged, and it worked with them. For us, it was a game changer because you could, and especially with COVID, you could actually see the patients. Usually it would be a nurse or the rec care staff with them 24/7, and you would have the physicians or the nurse practitioner sort of quickly making a diagnosis, et cetera, along with, any kind of, whatever their, oxygen levels, et cetera, were. And I would say, going back to legacy has used telepsychiatry, telebehavioral health for years. And I'm very good at it, and do thousands of visits that way. And I would say they've had the same experience, Dennis, is that actually people like it, and like, that kind of form of service. So I think you'll see more of that, John. And I think the biggest issue in that space is just to make sure that reimbursement levels don't go away.
Right.
COVID, and I think that's something you know, very much into policy. You cannot lose. If you go back to the old ways where you can't, you know, go across states, et cetera, with your provider, this has all been for none, and that's what we would be worried about. Right now, there's still an openness of using the technology, and all you can get reimbursed, and that's what we need to all fight for and continue to fight for as providers.
We are coming up to the end, and this has been absolutely wonderful. I mean, I have a list of questions we haven't even gotten to yet, but this is just fabulous. I want to thank both of you, not only for you know, doing this webinar with us, but for the work you're doing and the leadership and the innovation. It's just great to see this kind of stuff. So thank you again. Thanks for our audience. Got some good questions from them. Corey, do you have any last comments you would like to make?
Yes, I do. Thanks, John. Thanks, Dennis and Tine. I would like everybody to know who put in a question that we did not get to. I will be in touch with you. I have your name and email address. We also would like you to join us again next week. We have another part of our Executive Web Forum series, Designing Best-in-Class Websites, the Open Minds website evaluation and improvement process. And with that, I would also like to remind everybody the recordings and slides for this will be available tomorrow. I will also send that out to all attendees. And thank you once again to NextGen Healthcare. If you enjoyed today's topic, we invite you to join our community at integratedcareonline.com, powered by NextGen, for more integrated health clinical content, best practices, and strategic insights. John, Dennis, Tine, thank you again. This has been wonderful.
Thank you.
Thank you.